All right, so let's give this just a sec to let all of our attendees get into the meeting.
Oh, wow, we got a bunch of them already.
Yep. Give it about maybe 10, 15 seconds. Everybody should be in. They are. Okay. So hi, everybody. My name is Bryce Hiller. I'm a digital marketing specialist here at Whitmix. And before we actually start the webinar, I'm going to take care of a few housekeeping items. So first, you should see a questions box down at the bottom of your Zoom screen. Feel free to type in any questions you might have throughout the presentation. And then probably at the very end, Dr. Melkers will be answering those questions. Next, this webinar is approved for 1 hour of PACE, AGD, CE, and NBC credit toward recertification. You'll receive an email within 1 to 2 days that will tell you how to obtain your credit. Lastly, this webinar is being recorded, so within 24 hours, it will be up on Whitmix's website and the webinar section, and it will also actually be on our YouTube channel, and we are streaming live to Facebook. So any of those 3 places, if you want to go back and watch this, you can do so. And I now have the pleasure of introducing Dr. Mike Melkers. Dr. Melkers is a 1994 graduate of Marquette University's School of Dentistry and currently serves as visiting faculty at the Pankey Institute and Riga Stratens University in Riga, Latvia. Dr. Melkers is a master of the Academy of General Dentistry and holds fellowships in the ICOI and the American College of Dentists. He is the Director of Educator Development for RIPE Global and regularly lectures around the world on a variety of occlusion, communication, and treatment planning topics. He maintains a full-time private clinical practice in Hanover, New Hampshire, with a focus on comprehensive adult restorative care. Today, Dr. Melkers will help explain the destructive forces that threaten the restorative success and how you can realistically manage those forces. It will also, this webinar will also explain the relationship between function, parafunction, and aesthetics. That's all I've got. So Dr. Melkers, if you're ready, let's begin.
Thank you, Bryce. I really appreciate that. And let me just get my share screen up here and get that playing. I want to thank Bryce and Bernie and Lorena and everybody at Whitmix for having me. We were just talking about the Midwinter and the Equilibration Society, and I've had just a wonderful relationship with Whitmix my entire clinical career, which goes back 27 years. But even before that, I remember going to the Midwinter with my dad and just having a wonderful time. So this is, for me, this is much more like a family reunion and sharing with old friends and colleagues. And what I'd like to share with you today, we called this Occlusion 101 to 911, but really what this is about is it's about keeping your restorations and your reputation intact, because occlusion is not that exciting. Well, it's exciting to me, but what can get really exciting is failure, and failure not in a good way. That is excitement not in a good way. So when we're looking at the current status of dentistry online and in social media, you tend to see a lot of Instagram before and afters, and those forums, people's reputations will be very high. And that's nothing against those people. I've been that person. I'll be that person again. But when we look at simple before and afters like this, we're not being told the whole story. We're not being told the whole challenges. When I think about occlusion, I think about not what I need, I think about why I need it. And because I need occlusion so I can walk into that operatory with confidence that I'll be going to be able to do my best job. And I need occlusion. Why? Because I need to walk out of that operatory with that same level of confidence that I can sleep well, that I can walk away from my clinic knowing that I've done my very best to help those restorations last. So the other thing that occlusion can help you with and help you build is not just beautiful smiles, not just beautiful teeth, but your reputation. Because broken teeth are very easy to fix in most cases. Now, a broken reputation, on the other hand, can be very, very difficult, if not impossible, to get back to its original untarnished state. So I guess if I could go back to dental school and I could rewrite the occlusion curriculum, really the whole curriculum, it would be, how do you want it to look? How do you make it fit? And how do you mitigate threats? I come at occlusion and I come at teaching a little different than some others. And that is, I'm inspired not by success, but I'm inspired by avoiding failure. And I know that's two sides of the same Janus coin, but when I think about it, I think about the journey that I've had in my own clinical career. The greatest accomplishments that I've had of avoiding those failures has been because of the gifts that so many mentors have given before me. Dr. Frank Spear, Lincoln Harris, Gerard Sheesh, Newton Fall, they all share very honestly and very realistically the failures that they've occurred so that they can help us avoid those same things. So I'd like to kind of walk through with you the fear of that failure and how we might look at some red flags over this next hour. So if we look at failure that happens every day in our practices, hopefully not every day, but you have this patient that comes in with this incisal facial fracture on an upper central, and you fixed it. And the second time you fixed it, you used Gradia, and that looked pretty good. And the third time you used TPH. The fourth time, I think you used Filtech. The fifth time, there was a new Gradia. Who's been there? Who's done that? And that's the reality of occlusion. It isn't just about the special occasion forces. It's not just about full mouth rehabilitation. It's about keeping these sort of restorations intact because we're frustrated, our patients are frustrated. And the other thing is, these are costly restorations. And I don't mean they're expensive for the patient, they're expensive for us. Because when we're doing this over and over and over again, money is just flying right out of our wallets, right out of our practice, right out of our team bonus, right out of our retirement stuff. So when I look at these cases, what I want to think about is, how is past prologue and how is what I'm seeing going to help me avoid that same situation in the future? Because when we look at Carl here, you see a lot of things going on. And I can't remember how I ran across Carl, but I'm pretty sure I came across him in hygiene. And I said, "Hey, Carl, how's it going?" He said, "Great." And I said, "Tell me about great." And he said, "Well, Lori says I'm brushing and flossing really well and things are looking nice." And I started to look at Carl and I look at the left side of your screen and his back teeth are white. Then I look at the right side of your screen and the back teeth are silver. And I said, "Carl, can I ask you a question?" He said, "Sure." And I said, "I'm looking at your teeth and half of them are silver in the back, half of them are white." And he goes, "Yeah, I was going to ask you." He goes, I said, "Why?" It's like, and he said, "Well, they used to both be white." And I said, "Well, did you chew on rocks? What happened with that?" And he goes, "No, just over time, the porcelain, and I'd wake up and there'd be some white stuff, crunchy white stuff in my mouth." And what he had is he was breaking off porcelain regularly. Now that full mouth rehabilitation that you just saw in Carl was done 7, maybe 8 years ago. And I think about the reputation and the restorations and how those are really interlinked and how those can threaten not only our success, but the longevity of our reputation. Because reputation goes along hand in hand with risk. If we take no risks, we can't damage our restorations, reputation so much, but we can also build it. So the higher the risk cases that we tackle successfully, the greater our reputation is built. People hear about us, people refer to us, not only patients, but also colleagues, also specialists. Now, the other thing that we're living in right now is we're living in a time where we have, as always, the greatest, strongest, best lasting, whatever you might call it. I think all the way back when I graduated in '94 and we had the latest, greatest at the time was art glass, Bell glass, all these things you don't even hear about on the market. But if you think about high strength restorations that we have today, if I say, aside from gold, I say, what is on the market that is the strongest, best, going to last the longest? And you're going to say lithium to silicate, or you're probably going to say zirconia. Well, here is a zirconia, porcelain fused to zirconia restoration. And what you see after, and this is one of the gifts of COVID, this patient, I think, broke 7 or 9 teeth during COVID. What you see is the gift of COVID, dark gift, is that our patients are breaking restorations, and they may be older restorations, they may be newer restorations, but what you see on the screen is not just the fracture of the veneering porcelain, which is the weak link in this case, what you're actually also seeing is a subsurface substrate that is a fracture of the zirconia core. Strongest, latest, greatest materials that we have available to us. If you look at the lingual surface of the lateral incisor here, you see a monolithic zirconia core fractured. If you look at the right side of the screen, you see a monolithic lithium disilicate fractured. And even if you look at the gold restoration there, you see gold restoration perforated. Latest, greatest, strongest materials. If enough force is applied, it doesn't matter what they are, whether they're glass, enamel, gold, dentin. If enough force is applied to them, restorations will break, restorations will be damaged, and our reputations will be damaged. So what I'd like to share with you over this 1 hour program is talk about some of the red flags that we see and things that we can do to help avoid or at least mitigate or minimize these type structural failures. So as I said, if enough force is applied, and you can look at this is a patient that I actually performed a full mouth rehabilitation on a couple of years ago. And previously you saw zirconia, you saw Emax, but I like to show you, even in the presence of gold, that these materials are not impervious to these destructive forces. And, you know, the bad day is when the gold isn't in the mouth. The bad day is when the gold is out of the mouth. And that patient comes in and, you know, they either have it in the handkerchief or in a little Kleenex or a baggie or a medicine bottle. But here you see a beautiful gold crown, and the gold crown survived just fine. It's the patient that failed. It's the structural fracture of not only the amalgam core that you see there, but you can see the substrate, the enamel and dentin are fractured off. So what are these red flags that I talk about? And it would be so nice if they were just glued and pasted and posted all over the patient's face. Because when we look at these variety of patients, you can look at someone like Roger here, and the red flag is glaringly obvious. And it says, be afraid, be very afraid. This is the patient that you saw that I showed you just a couple slides ago, where he was chewing through those gold restorations. And Roger comes to you wanting a full mouth rehabilitation. Roger says, here's a big bag of money. Fix me and make it pretty and make it last. That's where the challenges come in with these red flags that I'd like to go over, is how to make you feel more comfortable, how to help our patients feel more comfortable with the process, and also confident and more confident in the longevity of the restorations. So it would be really, really nice if those red flags were just so glaringly obvious as they were if they put them around a volcano and it said, don't swim, or don't lick the chainsaw blade while it's running. You know, those are things that we know inherently. In dentistry, honestly, we weren't taught failure very well. We started seeing patients probably our second year of dental school, and we maybe had to make it 18, maybe 20 months treating patients, and then we can get out of there. And Marquette University, they gave us the benediction, and off we went to not hurt patients. So if I could cover a couple or a few red flags that can perhaps help you out tomorrow and in your practice moving forward. One of the huge red flags that I see when I'm treating worn dentition dentistry is exclusive second molar wear. Now, if you look at this picture, you might say, Mike, what are you talking about? There's wear everywhere. Yes, there is, and there's wear on the centrals, the laterals, the canines, the premolars. But what you see on the second molar there, on the palatal cusp of number 15, is you see what looks like a black spot. It looks like acufilm or some kind of articulating film. But what that actually is it's a perforation in the second molar through either non-precious or semi-precious metal. Huge red flag. And when I get into treating full mouth rehabilitations and worn dentition dentistry, this is a red flag that tells me that when the muscles are at their highest level of activity, I do not have distribution throughout the arch, and I'm only hitting on that second molar. And then think about that gold crown that you just saw that was fractured off. The strongest, longest lasting material, gold, even in the presence of the greatest forces, it can still fracture that tooth right off the gum line. Now, from there, I'd like to actually jump up to the front of the mouth. And one of the other things, one of the biggest breakthroughs for me on failure mitigation and identifying destructive forces was incisal-lingual chipping on lower anteriors. Now, what this means to me, and once you start to see it, I apologize, you're going to see this on all your patients starting tomorrow. And what we see there is when people move past edge to edge, that is, they have disclusion of canines or central incisors. And when they go past edge to edge, they're going down that trailing edge. That is the lingual incisal of the lower teeth. And what you're seeing there is the enamel is chipping. And what you're seeing there is the dentin is getting exposed. And slowly that dentin will erode more than enamel. And over time, dentin wears 10 times faster than the enamel. The enamel ends up unsupported. Then the teeth start fracturing. Then the teeth start super erupting, and so on and so forth. Now, very closely related to that, I'd actually like to show you a facial incisal fracture on canines. And thinking back to that composite case that you saw in number 8 that broke again and again and again, much like the last slide that you saw where people were going past edge to edge, this is the same thing as we're going canine initiated disclusion, they get past edge to edge. And when they come back and forth over that leading edge, trailing edge incisal table, you have this unsupported porcelain, even on canines, way up at the incisal edge, that is going to experience structural fatigue over time. That is cyclic loading, cyclic flexure that leads to the fracture of the canine. So when we were in school, we were given some book that had lots of dots and lots of lines. And while I love that book and greatest respect, whether it's Dr. Dawson or Dr. Occlusion or Ramsford and Ash, is we got too confused too early, and what we needed was simpler rules. And Dr. Pankey said it was simple. He said, when the patient closes, the teeth should touch without deflection. And when the mandible moves, the forces should be minimized. And all that has to do with is two components of failure mitigation. That is distribution and load and reduction in shear. That is, if someone is clenching and closing and crushing their teeth in restorations together, let's distribute that load throughout the entire arch so it can be shared. Now, the second part of Dr. Pankey's saying was that when the mandible moves, we want to be able to minimize the forces as they get up onto those fragile incisal edges that you saw in the composite, that you saw on the rehabilitation, that you saw on the facial incisal, that you saw on those lower incisal edges. So that is our greatest challenge in force mitigation, is distribution and load, reduction in shear. So how do teeth touch, and more importantly, why? And I said, how do you want it to look? How do you make it fit? And how do you mitigate forces? Well, that also has to do with teeth in the back of the mouth. So when we look at teeth in the back, all we're doing really is in this gold crown that came back that was out of occlusion, all I did was added some sticky wax, and then I put a little bit of gray wax there. And what I did is have the patient close, tap, tap. And what they created was a flat receiving area. Now, there's not a whole lot more to it than that. Posterior occlusion is just having a flat receiving area in the back that is axially loaded. Why is that important? Well, if you saw the failures that you've looked at, whether it's gold, glass, enamel, composite, porcelain, zirconia, or lithium disilicate, every single one of those materials deals better with load than flexure. They deal better with load than shear. And that is, you could take a glass plate and you could put a 100-pound weight on it. And if it was flat and touching that, nothing would happen to the plate. But if you took a piece of that plate and put it up on edge and you held it and braced it and pushed on it hard enough, you would snap that plate right in half. The forces that are affecting that plate aren't a whole lot different than are affecting the dentition. So these dots, honestly, can be wherever these dots need to be. Wherever the opposing cusp is, we can put a landing pad. That is, you have a cusp on one tooth, and on the opposing tooth, you have a flat receiving area. And if I could make it as simple as that, that's all posterior occlusion is about. So if we look here, and this is a slide from Dr. Lane Ochi, a good friend of mine and also my teaching partner, is you can actually hide these landing pads in this beautiful gold crown. You can see the mesial, distal, marginal ridges, the cusp slopes, the fossas, and then what you have is two slightly elevated receiving areas where you see those two blue dots. And I'll get into why elevated is important and how we might achieve that. But if I could look at axial distribution versus incline contact, and this is a little animation from BiteFX. And if you go ahead and have the patient bite and they're hitting on the left side of the screen here, they hit on the left side of the screen there, and the load is going to go down the axial long axis of the tooth, versus if you hit over here and you hit on an incline, what would happen on the left side of the screen is the forces would be distributed through the long axis. On the right side of the screen, what you would see is the tooth would either go into fremitus, that is, if we're hitting on an incline, you could move the tooth, or if the tooth is so solidly anchored that when you hit on that incline, you can fracture that cusp tip. So in an example here, this is a full mouth equilibration or trial equilibration that I'm doing on the models on my 320 articulator. And what we see there is that first point of contact in CR. So not important that we're not getting into full mouth rehabilitation webinar here, but if this is the first place that the patient touches and I want to work towards that equilibration, or even if it's just that I did a composite restoration, and I see that when the patient is touching, the lower buccal cusp is hitting on the buccal slope of the upper palatal cusp, and the upper palatal cusp is hitting on the lingual slope of the lower buccal cusp. Now, that isn't so much the problem. The problem is where that force is directed. Now, you might think that when that force is directed down the long axis from the upper second molar to the lower second molar, it would continue through. But the force is actually directed perpendicular to that contact point, and you see that going out that way. And that's how we can see cusps fracture. That's how we see porcelain break, as you see on this porcelain crown, is that perpendicular direction of the forces is what leads to the material failure. So with those forces being directed in that, how can we correct them? Well, if you look at this slide, what I've done is I've drawn in some black lines, and that is an equilibration, a reductive equilibration. I've reshaped the lower buccal cusp, moving the cusp tip more to the buccal, and I've reshaped the palatal cusp to move the palatal cusp tip more towards the lingual or the palatal. The purpose here is that these new cusp tip locations achieved through equilibration are actually facing the flat receiving area that you can see on the opposing tooth. The flat receiving area being critical and paramount to that long axis loading in achieving that compression. So what if we didn't do that? And going back to that, well, we see a lot of occlusion sort of drawings like you see on the right side of your screen. And that's certainly how I learned, was balanced tripod occlusion, where I have something on the buccal slope, something on the lingual slope, and they balance out. Now, the challenge with that is if you look on the 2018 pre-op on the top of the screen, you have an asymptomatic patient with no restorations on that first bicuspid. Now, what you see on a year later and COVID rolling in, people grinding, people clenching a lot more, is what you see is that tooth is split in half. So if I could look at it diagrammatically, just using a hammer, and if occlusion's hammer, I say you better have a nail handy, because what we see here as this hammer comes down onto this upper molar is you see the nails are directed in the wrong direction. So the nails, that is, remember I told you the forces of the contact will be redirected perpendicular to the contact. So even though that vertical nature of closure is bringing those forces axially loaded, once they hit the incline, they're actually acting as a splitting wedge, as you just saw, and driving that tooth apart. So, well, what if we went ahead and made that flat receiving area there? This is definitely a huge improvement, and we definitely would have axially load here. The challenge, though, is what if that restoration is high? So if that restoration is high on that upper molar, and you actually needed to adjust it, and you can see maybe the white line as I've adjusted that a little bit, now you're not hitting again in that flat receiving area, you're actually hitting on the incline on that buccal and lingual cusp slope, and you're leading that to be driven apart again as that splitting wedge. So if we could take that nail concept in the flat receiving area, the occlusion or the landing pads, what I've done is I've elevated that nail away from the depth of the fossa, and now the hammer can be received by that nail on a flat receiving area that's driven down the long axis. Now, if you see that diagrammatically drawn in with the white lines, what I've done is I've brought up a landing pad on the upper proposed crown. And what that landing pad allows me to do is have a flat receiving area for the lower cusp. But it also allows me, because that landing pad is elevated, that if that crown is a little high, I can actually just take a brownie or a greenie, or if I need a white stone, and I can actually shorten that landing pad, but still leave it elevated, and leaving it elevated so that we can avoid the hammer contact on those inclined slopes. What we could also do in those cases is we could also adjust the opposing cusp. And as you saw here, what I've done is I've taken the hammer or the opposing cusp, and I've actually narrowed it buccal lingual so that it is hitting that flat receiving area. It's hitting that nail on the head, and it's avoiding those cusp slope contacts. So dots in back, lines in front. So we've talked about in the last 15 minutes or 20 minutes or half an hour, we've talked a lot about the dots in back. So I'd like to talk now a bit more about the lines in front. And the rehab that you see here again is Roger, the patient that chewed the gold crowns apart. He was also the patient that you saw from the facial view that was destroying all his dentistry. And this is where we've gotten close to the delivery of the final restoration. So if you see on the bicuspids, you can see a flat receiving area on the distal marginal ridge. You can see a contact on the palatal cusp of the first bi. And then you can see dots in front and lines, dots in front and back. And you can see also the lines there with the canine disclusion and also the central. Now, why is anterior disclusion important? Because we were told so, because it was in a textbook. Well, if I could look at this study from JPD that was published in 1999 by Dr. Erwin Becker, Gregory Tarantola, and Zambrano and others, what they showed was the use of an anterior midpoint stop appliance reduces the voluntary clenching activity of the masseter and the temporalis by down to about a third of maximum. That is, the use of an anterior midpoint stop appliance can reduce clenching, crusher, closer, destroyers of dentistry muscle activity by 70%. Now, if we look at that and how that goes, and what I did here was I did an EMG study, and I had patients clench, and I said clench in MIP, teeth together. So you see on the left side of your screen, the MIP peak. And then I took a piece of plastic and I put it between the centrals, and I said, clench as hard as you can. And then lateral to lateral, canine to canine, bicuspid to bicuspid, and then first molar to first molar. What I would like you to appreciate here is not just the reduction that you have from the first molar down to the central. What I'd like you to appreciate is look at what the highest peak of a canine is compared to a molar. Now, what you're seeing here in this diagram of this EMG is that canine EMG muscle activity in the temporalis and masseter can be as high at its highest peak than the molar is at its trough. So when you saw those destroyed canines, canine guidance isn't always what a patient needs. And Dr. Frank Spear says if a patient has worn canines and destroyed canines and you give them back longer canines, what should you expect? Destroyed canines, because there's a missing piece on that we're going to talk about before I close up the program. So as far as the reduction of the forces in lateral excursion, so now instead of closure, what you're going to see is movement here. So if I go ahead and play the little video, what you can see on the left side of the screen is they're starting an MIP And as they go left and right, they have some anterior guidance that you can't see here, which is helping them avoid the cusp slope inclines, helping them avoid the shear or flexural contacts on the enamel or the porcelain or the composite that would lead to these fractures. So on the right side of the screen, when you see that movement, what you see is people breaking restorations. So let me just get my AV here together. And let's take a look at this. And you see that first bicuspid that doesn't look like it's moving. Actually, everything else is moving. And what that patient is doing, remember I said the teeth either break or they go into fremitus. So number 12, or depending on where you are, 2, 4, if you look at that first bicuspid in the upper left, as the patient goes back and forth and clenching, you can hear it clicking, you can see it moving, but what you have is a loose tooth. And if you don't have a loose tooth, then what you can get is a broken tooth. So contacts on inclined slopes, as I showed you, and whether it's in the video or these restoration, or that natural tooth that you saw in the video just a second ago, this is what leads to posterior failure. Not only looking at the porcelain fracture on the first molar, but you also have a mesial marginal ridge fracture. This cusp is completely separated, and you see some abfractive type lesion on this porcelain crown. So back to Roger, and back to this being scary and what we can do about it. When we look at the destructive forces that you have here, distribution and load is helpful for Roger when you look at all the gold crowns he's munched. But in the anterior, we need that reduction in shear. So as I said, restorative dentists, our biggest threat is, failure in force management, failure mitigation, is decreasing that resistance and shear. So if you look on the left side of the screen, you see that lateral incisor clipping the lower canine, and you're getting fracture of the upper lateral. If you look at the middle of the screen, I've showed you this picture before, that's that facial incisal fracture that you saw, unfortunately, on a full mouth rehabilitation that I did about 23 years ago. That was about 7 years later, where you see that first molar that's fractured there. So how do we reduce resistance? Well, if you look perhaps at the middle of the screen and say that's our starting point, if we want to reduce damage, you want to reduce failure, you want to reduce fracture, we can either reduce the overlap or we can increase the overjet. That is, we either reduce the overlap and the time that the people are in resistance, or we increase the overjet, which decreases the angle that people are in resistance. So we're either decreasing the time by decreasing the overlap, or we're decreasing the angle, which is increasing the overjet. So looking at this patient here, what you have on Annette is she came to see me for some aesthetic, restorative, but also structural improvements. And on the upper anteriors, you can see that she's obliterated her canines, turned them into vampire fangs. She has older failing composite bonding on number 7, 8, and 9, and the lower is pretty decimated. But if you look on the lower right side of the screen, what you also see is you see that there isn't a lot of room to put anything. And so reducing the overlap can involve increasing the vertical, or it can include having the condyle seat to a more seated position. You can use the term CR, but as the patient's condyle seat, you actually will see opening in the anterior. So in Annette's case, without getting into a big lecture about rehabilitation with Annette, she wanted to improve the look of her upper 6 teeth, and she also wanted them to last. So making them last is the force mitigation that involves doing some corrections on the lower. So yellow dots are where Annette started, and white lines is where we'd like to help her end up. So treatment planning 101 is, like I said, it's just, how do you want it to look? How do you make it fit? How do you mitigate forces? So in Annette's case, what we were able to do on the left side of the screen, taking her from MIP, we used appliance therapy. In this case, one of my designs that I didn't come up with it, but I helped refine it quite a bit. The dual arch anterior scribe appliance. And what you can see here is, and that goes from MIP to a more seated position. That is when these teeth on the left side in the skull view were together. And then as she went to the more seated position, she actually opened up room in the anterior. And that room in the anterior now allows for lengthening of those teeth a little bit, which is one of her goals, and also helping make them last. So when the patient closes, the teeth should touch without deflection. When the mandible moves, the forces should be minimized. Here, the way we accomplished that was we leveled the lowers a bit, couldn't completely level them without doing ortho, which she declined, or basically grinding them off to the height of the papilla, which would be quite aggressive. But we crowned the upper 3 to 3, canine to canine. We did some composite bonding on the upper bicuspids. As you can see, the landing pads that we created here and here on the bicuspids, these are all direct composite overlay bondings that we did there. And what that brings us out to is helping Annette achieve her goals and also mitigate the destructive forces that go along with that. As my friend John Canariato down in Tampa says, build it, protect it, and pray. Because everything that we can do, whether it's reducing overlap, increasing overjet, distribution of forces, there is a point that no matter what we do, how much force is applied, we'll overcome that. That said, I don't want everyone to lose hope that historically, we've looked at joint position, helping people stop grinding. We've looked at vertical. We've looked at the way the dots are. But the one thing that has maintained constant in helping us improve our successes and avoiding the failures is adherence to strong biomechanical principles. So when we look at that and reducing resistance, in this case, we're looking at Richard's case, and Richard came in with honestly a concern about number 7 or number 1, 2, the upper lateral. And as we got into it, I told him that he also had some decay on number 9 around the other crown. And then I started to point out those little shadows that you see on Richard's teeth on the other central incisor and the other lateral. Richard also talked about how he didn't like the lower central incisors, how brown they were. So if we look at Richard, and he's probably about 74 years old, I think, when we treated him, is he had a lot of decades to get where he is with the damage to these teeth, but we'd still like them to last as long as possible for the next decade or two. So increasing overjet reduces the resistance. So if we look at some of the challenges that we can communicate with our patients, not only with what they see, but also what we see. What I like to do in this case is I'd like to say to Richard, I say, can you look at number 7 or I'm sorry, number 8 or number 10? And I say, can you see how gray your tooth is up at the incisal ledge? And he says, yeah. And I said, well, it's not gray, it's actually see-through. And what I can do is I can take a periodontal probe and probe down the palatal surface of the central incisor, and I can see where that enamel has been worn away, and I can see where that dent's been exposed. And then what I can do is I can move that periodontal probe over to the facial surface, and I can show Richard how much risk he is at for shortening this tooth. And I said, Richard, do you like the way this tooth looks right now? He goes, yeah, it's all right, I don't mind it. And what I might say is, I said, well, if I take the perioprobe and go back to where the wear is on the lingual or palatal surface, and I bring that to the front, I need to let you know that it's possible that your tooth can become that short. And he said, well, I don't want that to happen. What can we do about it? And those are kind of the magic words, is the patient asking for help, the patient asking for an outcome. They want help. They want the smile to look better, and they want the restorations to last. So in Richard's case, we decided, and he decided, that he'd like to improve the upper 4 appearance as well as address the decay. And he'd like to address the lowers there by improving the way they look. Now, yes, you could argue ortho on the lower, but ortho isn't going to change those brown colors to white. So in Richard's case, what we're going to do is we're going to lingualize the lower incisors. We're going to basically retrocline them. And rather than traditional orthodontics or aligners, we're going to be doing instant orthodontics, which is just moving those teeth back restoratively. So in Richard's case, as 24 and 25 are proclined, we can retrocline them either with traditional orthodontics, or in this case, we're actually restoratively retroclining them. What that allows us is room on the palatal surface of the uppers to not only restore what was lost, but also in that case, decrease the increase the overjet. Now, increasing the overjet here actually decreases the angle of disclusion. Decreasing the angle of disclusion decreases the resistance to disclusion. Decreasing the resistance to disclusion increases the success and decreases your risk of structural failure. So in Richard's case, what I did here was I just went ahead and worked with the dye stone. I dug into the incisal edges. I put a little sticky wax there. I waxed up, excuse me, number 24 and 25, at least diagrammatically. That's not a perfect aesthetic wax up, but this is really force mitigation so that I can see how I want to achieve this. And so I can speak with my technician. Now, in this case, what we also did was we did a custom incisal guide table, which you see on the guide table down here. You have the incisal pin and you have some acrylic that's been sculpted out for all the motions that matched all of those destructive patterns, all those wear patterns that you saw in Richard's case. And then once we've done that and we've moved and retroclined that lower incisor back up, I actually hollowed out the palatal surface of the upper centrals. I put some molten wax, and then having the patient go through the excursions, what we see is the angle that's on the custom incisal guide table is transferred in that same angle to the palatal surface of the maxillary centrals, and it sculpts out the palatal surface up there. Now, when we look at that, what we finally come up with, excuse me, I just need a quick sip of water. Apologize for that. What you see here is you see dots and you see lines. And you might say, where are the dots and lines, Mike? Well, back in the day, I guess, and this may be true or not, they asked Michelangelo, they said, how can you carve such a beautiful David, such a beautiful Venus? How can you carve such beautiful sculptures out of a big block of stone? And what he said was, I don't see the stone, I see the Venus, and I see the Michelangelo, or I see the David, I mean. And what we see here is the dots are right there and the lines are right there. And everything else is superfluous. So if I can maintain those lines on the mesial and distal marginal ridge, I can put the dots there, and then I can carve everything else away. And you can see that we have the palatal fossa. We even have some fancy cingulum, and that looks like a tooth. Now, it's not just important that it looks like a tooth, because that would be a little silly to go through all that effort when you're doing the palatal surface of a maxillary central. But back when I was talking about the landing pads, remember, if the landing pad was on a flat receiving area and not elevated, that when you adjusted it, you would be digging a hole. Well, if any of these lines on the mesial and distal marginal ridges were high or rough, and it was on a completely flat surface, and you adjusted that, you would actually be creating a divot or a dimple in there. Whereas if you have these mesial and distal marginal ridges and these lines, these discluding elements on an elevated surface, and they're high or rough, all you have to do is blend them through that process. And I know that's a lot to take in just a short webinar, and without some audio visual and drawings and all that and sitting around with beers, but I hope that brought that across a little bit. Dots and back, lines in front, that's all that occlusion and force mitigation is, and what we've covered here in this last 45 minutes. If we look at this, and I said, and I'm pounding that in, our greatest challenge in force management is distribution and load and resistance and shear. So if I could pull some of those concepts together just a little bit here, this is a wax up that I have that I did for a dentist, maybe, gosh, had to be, I'm thinking 20 years ago. And Bob had a fairly severely debilitated dentition, not to the level of Roger, but if I could put together just conceptually for you some of the, how I applied some of the process, is right now what you see is you see the patient in MIP. And in MIP, this patient is at 100% muscle activity. So as they start to go into that disclusive pathway that is into excursions, in this case, on the left side of the screen, you see Bob going into right lateral. And on the right side of the screen, you see him going into left lateral. And as he moves, he does not hit that lateral incisor, because this showed you that before, as you're moving from 75% muscle activity on that canine, if you're clipping that lateral, that's where you're going to get some broken glass. As we move and continue through that 70% recruitment with canine initiated disclusion, we're moving through that thick body of the canine, lots of supported tooth structure, lots of supported porcelain. But now as we're starting to get up towards that incisal edge, that's where that porcelain isn't as supported and it is not so robust. And then you think back to that facial incisal fracture on the composite case, or you think back to the facial incisal fracture on number 27 on that full mouth rehabilitation case. And what we want to do is we want to move from that canine to a more anteriorized contact. And here you see group function happening. And by group function, I don't mean, it doesn't mean back teeth, it just means group more than one. So we haven't reduced the muscle activity down to 30% quite yet. So now we're sharing the distribution and load in excursions between the canine, number 11, and we're starting to pick up number 9, that transition of crossover. And as that transition of crossover happens, and the canine cuss tip goes over the opposing cuss tip and goes to cross over, that's where I was talking about at the beginning of the program, how we saw the facial incisal or lingual incisal of lower anteriors. If there is not a smooth transition here, then what you would see is this number 9 up here could really be doing a number and damaging that lingual incisal or trailing edge on number 24. And as that continues through, we can see that that excursion at crossover, we have full transition to the central contact. You can't quite see it in the wax up picture, but we've completely left the canine. Now we're at 30% muscle activity, distribution and load, reduction in shear. And as you can see, Roger here, a number of years later, whether it's his mock-up on the left side of the screen, the pre-op on the center of the screen, or his final restorations there on the right. I hope that this last 40 minutes or 45 minutes or 50 minutes or so has been helpful for you. I'd like to very much thank Whitmix for hosting me, and they did give me permission, and I'll just throw a couple of things up here. If you're interested in finding out more about occlusion or about more of my programs, www.panky.org. At the end of March, I'm actually doing a program called Occlusion 101 to 911. Same title as this, but it's going to be a 2.5-day waxing course and equilibrating course with my laboratory technician, Lucas Lamont, down at the Pankey Institute on beautiful Key Biscayne. I know there are a few spaces left in that. Ripe Global, where I'm the Director of Education, Financial Disclosure. I also have quite a bit of my educational resources on there. It's a fantastic place to check out, as well as Ripe Global's Facebook page, which has 85,000 members all over the world with full protocol cases. Or if you just want to find out where I'm going to be in the world as we're traveling, and Bernie and I were talking about, we're finally getting to get out and about a little bit more, Bryce, is michaelmelkers.com. And as always, feel free to contact me at info@michaelmelkers.com. If I'm too busy, I'll let you know, or maybe I won't. But what I don't want you to do is miss that question or miss that resource. One of the things that I love about teaching is not just the teaching, but seeing the results of that. And that's why, again, I want to thank Whitmix so much for providing these platforms before COVID, during COVID, during the lockdowns. And now it's great to be back with friends. And Bryce, thank you for the last hour.
Yeah, absolutely. Thank you, Dr. Melkers. That was fantastic information, and I think everybody probably took a lot away from that. We did have one question that came in. And the question was, do you use a specific burr to cut off zirconium crowns?
Yeah, one I swear a lot next to, I think. Cutting off zirconia is actually counterintuitive. I do the intuitive part and I use like a black stripe super coarse. And I know a lot of people say that they like using red stripe fine grit diamonds. And I do that when I adjust them. But a lot of people say, finer diamonds will go through zirconia easier. I find that personally, when I'm using the black stripe, it will fracture the veneering porcelain quite easily. And it will actually, I think some of the vibration will help shatter the cement bond. So if I'm looking at retreating zirconia, which I absolutely hate, by the way, I'll use a combination of those two burrs.
Great, awesome, thank you.
You're welcome.
Again, thank you to everybody that attended. Thank you again, Dr. Melkers. We really appreciate your expertise as always. And I do want to let all of the attendees know that we are going to, you will have a poll pop up on your screen asking if you would like to be contacted by a Whitmix representative about the webinar today. So if you would like Whitmix to contact you, you can go ahead and answer that poll question accordingly. Again, I would like to reiterate that this is recorded and will be available on our website, on our YouTube channel, and on our Facebook page. And again, one last thank you to Dr. Melkers and all of our attendees.
Thank you, Bryce. It was wonderful being here with you guys, and I'll see you I'll see you actually this month. I'll see you in a few weeks in Chicago, I hope.
Just a few weeks. Awesome. Sounds good.
Take care, everyone. Thanks for stopping by.
Thank you.